Hi, my name is Julie Yates and I'm the transfusion specialist for the Trust. So welcome to our Trust. So today is your quick presentation on transfusion issues. So why do we need to be here today? Well, what we want from you guys is so that you don't send a sample in and it gets rejected. You need to know exactly what you want to do so that you've got the right procedures and the right tools at your hands. Because if we get it right the first time, then that's best for the patient. So at the Warrington site, just to tell you, the Warrington site is open 24/7 and haematology includes transfusion, coagulation, blood films. After 5 o'clock at night, haematology is staffed by one member of staff and a support carer in reception. After 8 o'clock at night, there's only one biomedical scientist in the laboratory. Therefore, it's essential that if you are sending any requests for blood, cryo, FFP, platelets, that you ring to tell us it's coming, because otherwise it can sit in reception. This way you get your request processed far quicker. The Halton site is open from 9 o'clock till 5:30, Monday to Friday. It's not staffed all the time. So out of hours and at nights, it's staffed by the biomedical scientists at the Warrington site. If you are working at that site, you need to plan ahead. So there's no point coming on at 5 o'clock at night on a Friday night for 2 units of red cells for your patient when the hemoglobin has been low in the morning, because that request will be sent to the Warrington site and that's going to involve taxis, porters to get it to you quickly. So plan ahead and your blood can be in the fridge for your patient. First of all, I want to talk about sample information. So we're going to talk about the request form. So on the screen behind me, you're going to see the request form, and all areas that are highlighted with the red circle or the red square is information that you have to fill in. So we need this filled in completely. And we also need, you can use a sticker on there with the patient demographics, but you need, if you're hand filling it in, you need to fill in all sections. We need where you're from, because believe it or not, people don't fill that in. We need clinical information, because without that clinical information, your request may not get processed. So even a group and save needs a reason for a request. And if you are requesting blood on that, you need to pick the phone up and ring transfusion. So group and save requests. You must give out clinical information, as I've said. Now the point of a group and save, it's generally a routine test. So that means that we will process it in the lab as per normal day. So if it's busy, it'll get delayed till later because it's classed as a routine test. However, if your patient is going to theatre or in A&E or at risk of a big bleed, then you must ring us and tell us it's urgent, and that way we will prioritise it, because there's nothing worse than asking for your blood and we haven't even started to process your group and save. So they're generally not urgent, but in those situations they are, and you must ring us to tell us and we will process it quickly for you. Now I've just got one slide that hopefully you can see behind me, and it's on about sample labelling. So if you are taking a sample, the most important thing is that you have your request form first. It is fully completed, because you are going to label that sample from the request form, but it has to be done next to the patient, and you have to have checked your patient's details with your request form and the wristband before you take the sample. So you take the sample, you check the details, you check the wristband, they all match, you take your samples and then you label them next to your patient. The most important bit for transfusion is that your signatures match. So please sign the bottle first. It's curved, it's round, it's hard to fill in, and then sign the form. Now, the biomedical scientist is a stickler for the signatures matching. So therefore, once you've signed the bottle, you sign the form like the bottle, so it looks identical. If you can't read it or it's an initial, you must print your name on the form. Otherwise, it will not get tested. It will be rejected and you'll have to start again. So that's a really important thing with transfusion. And the reason we do that is because on the next slide, you will see the wrong blood in tubes in 2019 in our trust. We only had one for transfusion, which was really good, but we had 45 for haematology and biochemistry. And what I mean by a wrong blood in tube is you take the sample from me and you label it with somebody else's details. So for those 45 patients, you can act on the wrong biochemistry result, the wrong haematology result, and you can result in a transfusion being given to the wrong person. Now, this is the tip of the iceberg, and it's always done because people don't check the patient identification. So if you are doing an ICE form, and the majority of these for haematology and biochem are on an ICE form, so if you've never seen the ICE forms, it's sticky labels that you tear off. People take the samples, walk away, and then request the request form. You mustn't do it that way. You must have your form first. If you are labelling a nice one, and this is really not transfusion, but pathology asked me to tell you this. If you're looking at the this slide now, there's all different ways you can stick that ICE form on. And if you don't stick it on in the right way, there's a good chance that it will be rejected, mainly because it can't go on the machine, or they can't read it, or you've covered the area whereby we can see the cells, because we need to see those cells. So the next part I want to go over is sample validity. Your samples for transfusion are valid for 7 days, and people get confused over this. So it's 7 days unless you have been transfused in the last 3 months, or you have been pregnant in the last 3 months. And if you have been transfused in the last 3 months or pregnant in the last 3 months, your sample is only valid for 72 hours, for 3 days. Now, where people get confused is that once you start to transfuse, your sample validity changes to 3 days. So say you're on a 7-day sample, and on day 1 you transfuse that patient. That sample will no longer be valid for 7 days, it will be valid for 3 days. And the reason for this is the patient can throw up an antibody that they may react to if we give you some blood. So therefore we want to check the blood group, and we want to check the antibody status of your patient. It's purely for safety reasons. The other thing that we need to know about blood provision is that if the sample is in the lab and it's ready for us, we've processed it, so it's already processed. On ICE it will say your patient is APARS antibody screen negative. If it's in there, they don't have any antibodies, and you need a unit of red cells, all you need to do is to send a request form in to say 1 unit of red cells, and your blood will be ready within 5 minutes. It's very quick. However, if we have a sample in the lab and they've had antibodies in the past, or the current sample has got irregular antibodies, then that is a manual cross-match. That manual cross-match will take us 45 minutes. So if I just go back a few slides and say, if it was a cross-match, if it was a group and save that you haven't taken and your patient's going to theatre, you take it at last minute, you send it to the lab, and you don't tell us, we find she's got antibodies, when you ring us up, you have to wait 45 minutes or longer for us to process the blood. That's why we say group and saves are not generally urgent unless you need that blood within the next hour or so. So it really is important. So if you're unsure, just ring transfusion and we will explain it to you. Now, the other thing we have in transfusion is a safety rule. And this is purely a safety rule. And I really want to stress that, because doctors get very confused with this one. And basically, if there's a historic group on the system, so if you go on ICE on our system and you can see a group, a previous blood group, APARS, OPARS, then whenever you need a valid sample in the lab, you only have to send 1 sample and 1 form. If there is no historic group on our system, so it basically affects A&E and A1 and the assessment unit. So if your patient's got no historic blood group on our system, you need to send us 2 samples. These samples have to be taken at different times by different people. So it's 1 sample, 1 form, another sample, another form. They have to be separated by time really, but you could do, and person, Person's the best one, time if not. So you go away, you do another job and you go back. It's purely for safety, because if there's no historic group on the system, you've took the blood from the wrong person. We could give you a unit of blood that could kill your patient. So it is a safety rule. This is abused by doctors, and they do two things. One thing is you take two samples at the same time and you cross the time out and you add 10 minutes onto it. It's not going to get tested. That's going to go in the bin. And the other thing you do, which sounds funny, but it's not funny, or at least it amuses me more than anything, is you send two samples at the same time. You take them both at the same time, but you label one form and sample at 9 o'clock, say. You label the other form and sample at 9:30, but you send it in at 9 o'clock. Now, we don't do time travel, so that sample is going to go in the bin. They happen more, I bet we get that once a week. So please, it's a safety rule. So the next slide is pretty quite forward. Don't try to cheat, because you will put your patient at risk and you will be caught out. So as the slide says, you will be busted. Okay, blood provision. So when do I transfuse? You know, what do I do? Well, the guidelines say, the NICE guidelines for blood transfusion is we transfuse only when necessary. So if your patient isn't bleeding or isn't on a chronic program, so your hematology patients, then generally the rule is that the hemoglobin, if it's around 70 and they don't have any heart problems, then you may need to transfuse, but please don't take it over 90. So the window is keep it above 70 and keep it between 70 and 90. If they have heart problems, then you can go with 80, and it's between 80 and 100. However, please check the hematinics if it's a medical patient and they are iron deficient, because you might need to give a red cell unit for if they're symptomatic, but you should be treating the iron deficiency. We have an anemia pathway in place, so please look at it on the Trust's website. So make sure you treat with iron, not a red cell unit. 90% of iron deficiency is usually due to gastro problems, where you would treat with IV iron if they are symptomatic, or oral iron if they are not. And then you would refer to gastro, because gastro will then look at why they are iron deficiency. Please do not send to hematology. Some facts. On most occasions, iron deficiency is due to blood loss, malabsorption, celiac disease, or lack of iron in the diet. So iron deficiency is not primarily hematology, so don't send to the hematology consultants. Blood transfusion is not a scientific treatment for iron deficiency in modern times, so please, you treat with iron and you give a unit of red cells only if they're symptomatic. Otherwise, as you will see, the bulldog, that's the hematologist, so please don't refer to them unless it's a genuine hematological problem. And the basic rule we have with transfusion is don't use two when one will do. So we should transfuse one unit, you should check the hemoglobin, and then you can give another. You can always have another, but please check the hemoglobin in between. This rule applies to all transfusions unless the patient is bleeding or they're on a chronic program. So your hematological patients where you know they're coming in for 2 units and they're going home, then that's fine. But otherwise, it's 1 unit, check the hemoglobin, and then give another. This way you will not over transfuse your patient. Back in the 80s, the 70s and 80s, there was there's an infected blood inquiry now, which is from the 70s and 80s. So if you've seen the headlines other than Brexit and the COVID-19 virus recently, Theresa May last year said we were to investigate all these incidents from the 70s and 80s. So as you can see, some examples on the slide whereby people have been given a transfusion and they've either got hepatitis C or HIV. And the most famous one for me in the 70s, so if anybody is younger than me, then you will not remember this, but the picture on the slide is Paul Michael Glazier, and he was Starsky from Starsky and Hutch. That was a big series in the 80s. Now, he lost his wife and his child through HIV. His wife had a blood transfusion following the birth of their child, and through breastfeeding that he lost her and the baby. So last year Theresa May announced that this would be investigated. So what we don't want is for the future for any of you people to be transfusing when you don't need to. So we transfuse when we have to, when the patient will benefit only. The SHOT report last year, so this is up to date, this is the latest SHOT report. So 87% of errors were human error, of which there was 20 deaths, 14 which were preventable, all of which involved a blood transfusion. So moving on to requesting blood, you must complete that request form properly. Ring transfusion, as I've already said, to tell them you're sending it. Now, if you are prescribing platelets or FFP, then let the nursing staff know to give these first, because these are given over 30 minutes and sometimes they are short expiry. So your platelets, if I was to order them now, would expire at midnight tonight, because there is a shortage of platelets and they have a very short shelf life. So tell the nurse to give them first before the red cells, because you'll probably prescribe red cells over a maximum of 4 hours. 2 hours if you can, but if they are got heart problems, then you go for 3 to 4 hours. Other facts, we don't stock platelets on the shelf. So if you really do need platelets for your patients, then get onto us quite quickly, because we have to order them from Liverpool Blood Centre. And then I would ask that if you order them, you use them, because if you don't use those platelets when we get them, they will expire and we will throw them away. And at the end of the day, somebody has donated these, they've spent time, they've given that time up to donate these platelets for your patient. Fresh frozen plasma, that's the liquid part of the blood, contains all the coagulation factors. If you need this, it's a frozen product, so it takes 25 minutes to thaw out. You can't have it immediately, so you do need to give us advice when you need it, and we will have it ready for you. Prothrombin complex, in our trust we use Beriplex. If you've come from other areas, they might use Optiplex, but please bear in mind that when we use Beriplex, it's calculated in a different way. So contact transfusion, you need to weigh your patients and you need the INR result, and we can give you the right amount of Beriplex. All of those need to be prescribed on our transfusion prescription sheet. So when is it available? Well, emergency blood is available immediately. It'll take 5 to 10 minutes for group specific blood from receipt of the sample, or 45 minutes from if it's cross-matched blood. And the way I always describe this is that it depends how I do my shopping. If I want to go to Harrods, then I'm going to get cross-matched blood. If I want to go to the market, or I'm not saying there's anything wrong with the market, but that is emergency blood, so that it will stop the bleeding, but it's not as good as cross-matched blood. You can still have a reaction with emergency blood or group specific blood. Prescribing red cells. Basically, if it comes from transfusion, it goes on one of my transfusion forms. So the next slide will show you what the form looks like, and if you press the keys and see where the boxes go, all that has to be filled in. By law, this is going to be kept for 30 years, and because of CJD, all transfusions, documentation from transfusions has to be kept electronically for 30 years. The last thing that came out of the National Blood Transfusion Committee is that we must choose wisely. So there's 5 stages. Consent, you need consent. It's got to be documented, and there's a room on our transfusion form for that. Iron deficiency, you treat iron deficiency with iron, IV iron or oral iron, not a transfusion unless they're symptomatic. O negative blood, you use it appropriately. We only use O negative blood when we need to, because there's not enough donors for to go around for all the patients that are genuinely RHD negative. How many units do I use? If you can use 1, you use 1. If you need 2, you can have 2. So it's use 1, check the hemoglobin, and you then have another, unless of course they're bleeding or they're on a chronic program. And if you are using platelets, there's specific criteria for platelets. So please refer to that, and then the lab will guide you to when you use platelets and need platelets, because there is not enough platelets to go round. And the last thing we want, and we are penalised on it by the National Blood Service if we throw platelets away when we should be using them for a patient. So emergency blood, I just want to go over the emergency blood and our major hemorrhage protocol with you. If you're looking at this slide, it's emergency blood it's emergency WHH negative blood. This is for females under 50 and males under 18. In our trust, for emergency blood, we use WHH positive for male patients and females over the age of 50. The reason we use the O negative for females under 50 is because they are of childbearing age, and if we give them a positive unit, they can make an antibody that can affect future pregnancies. So we use O neg for females under 50 and O pos for males and females over 50. We also have neonatal blood, and that will come to you in a yellow pack with a little teddy bear on. Now, the last slide there is the major hemorrhage slide. We have a major hemorrhage protocol in place. If you are working in one of the key areas, and I would say anaesthetics, A&E, theatre, ITU, then please familiarise yourself with this pathway, because there's a good chance you may need to activate it. And by activating it, you need to ring transfusion. For the rest of you in the group, if you're working mainly on the wards, then you don't really need to familiarise yourself with the pathway. But what I would say is the one thing you need to take away, that if it happens on a ward, the main thing you do is to ring transfusion on 2547 and they will talk you through the pathway. Please don't ring switchboard or go through any other means, because all it does is delay the blood to you. Because what we want to be able to do is to say, yep, the emergency blood is ready, here it is. And the last thing we can do that is if it goes through switch or somebody else. So if you're in a key area, familiarise yourself with the pathway. And if you're unsure, give me a ring, there is no problem there. If you're on a ward and you will never use this, the main thing about it is you need to remember to ring transfusion on 2547. So further information, you can, the little teardrop sign, if you find that app, that gives you all the indication codes for transfusion, and the hand one is the Berryplex app. And if you go onto that, it's really simple to use. It tells you how to calculate the dose. However, in the last 12 months in the trust, it's been the biomedical scientists that will issue you that. If it's a standard request, we can issue it without a consultant haematologist authorization. So just ring transfusion with the weight, the INR result, and we'll sort that out for you immediately. So that's all I've got to say. So hopefully it's clear. If it's not, please give me a ring on 2547 or 5199. My email, you can email me or bleep me on 052. Thank you.